the contact, the brass wire protects the interdental papilla. So these are few of the steps that can be done to ensure that the soft tissues are not damaged. Also, try to use cotton rolls on the surrounding mucosa to avoid any iatrogenic damage to the mucosa. Then chemical method, actually it is not just use of a chemical, it is in conjunction with other mechanical or rotor reduction procedures. Here the proximal surfaces will be reduced following a mechanical abrasive method, and then the reduced enamel surface is further subjected to microabrasive chemical stripping, usually with 37% phosphoric acid or demineralizing agents. But after these chemical methods are not proved to be very efficient. Some researchers have also used the demineralizing agent before the mechanical reduction, saying that it softens the enamel and hence the mechanical reduction is more efficient. But the studies have not proved so. And so these are some of the techniques that are used for interproximal reduction. Coming to the major drawbacks or some myths that are surrounding this interproximal reduction are, first is it causes iatrogenic dental caries, because they say that since we are reducing the enamel surface, we are increasing the surface roughness of the enamel, which leads to more plaque retention, and hence it can cause more of a proximal caries, and also the plaque retention leads to increased periodontal problems. This was what was believed earlier, but there were several studies conducted, and they have proved that reduced enamel surfaces are not prone to iatrogenic dental caries or periodontal pathology if the procedure is carried out properly and the contact points are closed without any spaces between them. Then it actually reduces the caries incidence, proximal caries incidence, and also it reduces the periodontal issue, because as we can see earlier, there was something called as attritional occlusion, where in our aboriginal humans, they had a very coarse diet, like the food that they had was very fibrous, and hence the proximal and occlusal surfaces were worn out, and those skulls exhibited no proximal caries or periodontal problems, and also they did not have malocclusions like crowding or rotations. There are proofs of skulls without any malocclusion or periodontal problems. So as and when the food, the type of food that we started consuming became refined, our proximal and occlusal surfaces did not wear off as when we were having the coarse food. So this led to more of food accumulation, plaque retention, and more prone to caries and periodontal problems. So when we do proximal reduction, the point contact between the two teeth that we will be eliminating, and we will be creating a surface contact. That is when we do a proximal reduction and bring the two teeth close, a greater area of the proximal surface of the adjacent teeth will come in contact, and hence it reduces the dangers of plaque accumulation, and also they will be less prone to caries and periodontal pathology. So interproximal reduction is an efficient method of gaining space. And since it was more commonly used, I thought, why not study the surface roughness changes of this enamel? So a study was conducted, which was titled as Comparison of Interproximal Reduction Techniques and Proximal Strips, an Atomic Force Microscopic and Confocal Microscopic Study. This was my thesis, and I'll be explaining why these microscopes were used for the surface roughness changes. So it is as we all know from the brief introduction that I gave, IPR is a valuable method of gaining space, and there are many scanning electron microscope studies that were conducted to study the surface roughness changes of the enamel after interproximal reduction. But these were all mostly qualitative study measurements, but the surface roughness of the enamel in a microscopic scale, it is quantitative. That is, the roughness can be measured in a quantitative scale. So we designed this study by using an atomic force microscope, which actually surveys the surface of the enamel to check the roughness. So this is an atomic force microscope where you can see a silicone 20 nanometer. It is so small, 20 nanometer, a silicone tip, which will be mounted on a cantilever tip. And this gently moves on the surface of the enamel, and the oscillations will be recorded with the help of a laser beam, which is directed onto this cantilever, and a split photodiode receives these laser signals of the surface roughness, which is converted into the values, and it gives the surface roughness in nanometers. So objectives of my study were to study the enamel surface roughness changes between the handheld proximal stripping and aerotor stripping, which are the two commonly used techniques, and to study the outcome of polishing on surface roughness of the reduced enamel, and also to study the wear of proximal strips after the interproximal reduction. So coming to the methodology, we selected a total of 22 extracted premolars which were intact and collected after obtaining a written consent from the patients. And these teeth were cleaned with hydrogen peroxide and stored under normal saline. It was cleaned with hydrogen peroxide and saline and stored under 0.99% thymol solution. This thymol solution was used because it will not demineralize the enamel surface, and hence it keeps the enamel intact during the storage process. Then once the samples were collected, these samples were cleaned and mounted, dried and mounted on orthodontic stool. As you can see in this lower picture, they were mounted such that the root surface is covered and only the crowns are exposed. And then RVGs were taken for each tooth sample so that we select those premolars which have enough enamel thickness to subject it for interproximal reduction. Once the samples were collected, they were grouped under 4 groups and color coded. The black color coded group was considered as control group. It had 4 teeth, so that it means 8 proximal surfaces. Then group 2 was color coded as yellow, which had 6 teeth, that is 12 proximal surfaces. And here handheld interproximal reduction was carried on using a Horico company strip. I'll give the details of the abrasive strips in the following slides. Then group 3 considered we considered 12 proximal surfaces and were color coded as orange. And here handheld interproximal reduction was conducted using Ortho Organizer company abrasive strips. The last group was color coded as green, again including 12 proximal surfaces, and here aerotor stripping was carried out using Horico company burrs. So further, these proximal surfaces were subcategorized into with polishing and without polishing surfaces, color coded as blue and red respectively. And then each tooth was numbered under each group so that it helps us in easy identification. So after all this grouping, the interproximal reduction procedure was carried out. The handheld proximal stripping was done using a handle. As you can see here, this was a pre-manufactured handle. The proximal strips that were used were medium grit, single-sided, 4 mm wide diamond strips from Horico and Ortho Organizer. Single-sided means one side it will have the diamond coated abrasive surface, whereas on the other side it is just a metal surface. These proximal strips are used when you want to preserve the adjacent tooth enamel and want reduction on only one side. Also, when the contacts are very tight, both the side double-sided abrasive strips, it becomes difficult to engage it and open the contact. So in those places, these single-sided strips, they have reduced thickness. You can easily break the contact and then go for a double-sided strip. So here we considered single-sided abrasive strips. And based on the previous study, it was said that 40 passages, that is 1, 2, and 1 flow motion, is considered as one passage. Such 40 passages will So we followed this procedure with 40 passages of 6 centimeter long abrasive strips. Also, the polishing strips, 40 passages were carried out with 6 centimeter long polishing strips. So the aerator stripping was carried out using a tapered fissure burr used from Horico. You can see the design. It is very slender, long, and tapering. The diameter of the burr is very less, so that the maximum diameter is up to approximately 0.5 to 1 mm. It is not more than that. And the guidelines for aerator stripping is we should use gentle brushing strokes as given by Sheridan, and the same technique was followed here. The proximal surfaces were reduced up to 0.5 mm, and this was measured using a digital caliper before and after reduction to make sure that just 0.5 mm is reduced on both the sides. And the proximal surfaces coded blue in each group were polished with 3M Softlex polishing strips. These are available in the market. Then the proximal strip itself were subjected to surface roughness evaluation before and after reduction, because we wanted to know how much of the enamel, the strip surface gets abraded to check the efficiency of the strips. A confocal microscope was used for checking the surface roughness of the abrasive strips, because the surface roughness of the abrasive strips are too much, which cannot be measured under atomic force microscope because the tip is very small. So a confocal microscope was used, which captures the laser image of the surface, and then the surface roughness is measured using the software, using those laser images. So then after the procedure was carried out, the crown was separated from the root and then again split into half and mounted on clear acrylic as shown in this picture. The color coding was maintained. The blue dot indicates that it is a polished surface. The red dot indicates that it is the proximal surface which is reduced without polishing. Then these samples were sent for surface roughness evaluation under the atomic force microscope. A 20 nanometer silicon tip was used with a tapping mode of with a scan rate of 1 Hertz. A surface, the analysis. The mean surface roughness of the premolar proximal surface, different company proximal strips and 2 different reduction techniques, and also the effect of the polishing and wear of the proximal strips of 2 different companies before and after reduction were compared. You can see here this graph clearly shows that the polished enamel surface after reduction had a reduced enamel surface roughness compared to even the normal enamel surface. So it means that whenever you're carrying out an interproximal reduction, if you follow the procedure and finish it off with a polishing strip, the enamel surface roughness will become so smooth that it is even less than the normal tooth. And when compared to the techniques, the mechanical stripping produced less surface roughness compared to the aerator stripping, which was statistically significant. So mechanical handheld stripping procedure is always better when you want a smooth enamel surface. Amongst the 2 company strips, there was no great difference between the surface roughness. It was statistically insignificant. So both the company strips can be used, but followed by a polishing procedure. Even if the aerator stripping resulted in a greater surface roughness, after polishing, the surface roughness was reduced so much, even the enamel had great roughness. So Coming to the discussion of this study, the surface roughness created by mechanical interproximal reduction was less compared to that of the aerator stripping. And study shows that handheld mechanical reduction procedure is better than aerator stripping when it comes to enamel surface roughness. And it also matches with other studies which prove that handheld mechanical reduction procedures are better and safe compared to the motor-driven aerator reduction. The surface roughness produced by two commercially available strips was statistically not significant. So from both companies can be preferred. The enamel surface roughness of the reduced teeth after polishing were checked using the atomic force microscope, and they were smoother compared to the normal tooth surface roughness. Even the other studies showed that after aerator stripping, polishing gives a smoother surface compared to the natural enamel. So these images are the images obtained from the atomic force microscope, which shows the enamel surface roughness. This is the control group. These are the surface roughness of the teeth after the polishing, which you can see the roughness is less compared to the normal teeth. So we also check the roughness of the abrasive strips. These are the laser images of those abrasive strips before and after reduction. You can see before reduction, the abrasive diamond particles here, which gets completely submerged with the enamel shavings after the procedure. And if you remember, we have done 40 passages of each strip on each enamel proximal surface. So what conclusion we can obtain from this is the proximal strips must be frequently changed during the procedure to avoid the reduced enamel, reduced efficiency. Like if you keep changing the strips after almost 40 passages, then the amount of reduction that is obtained will be more, and also the procedure will be faster. So coming to the conclusion of this study, the atomic force microscope, it gives accurate, quantitative, objective measurement of the enamel surface roughness in nanometers. Handheld mechanical reduction procedure produces less surface roughness compared to the aerator stripping. And also the surface roughness of a polished enamel after IPR is smoother than the normal enamel surface. And the polishing of interproximal surfaces with the polishing strips following IPR is the best way of obtaining an enamel surface more similar to an untreated teeth. So this study proves that you can get a smooth enamel surface more smoother than the normal tooth and carry out this procedure efficiently, thus reducing the incidence of caries. And also if you create a good anatomy of the tooth after reduction, then it also helps in a better proximal contact compared to the normal tooth. So I'll be presenting few cases which are treated with using interproximal reduction. So coming to the first case, you can see here, he is a 22-year-old male patient who came to the department with a chief complaint of forwardly placed upper front tooth. When we examined him, he had a good lip fullness with incompetent lips, a gummy smile. His muscles were hyperactive, so there was a very greater smile. You can see in the profile he had a convex profile with lip fullness, incompetent lips. And intraorally, patient had a good class 1 molar and canine relation. There was spacing in the upper arch, proclined maxillary and mandibular teeth, and mild crowding in the lower anteriors. So he was a vertical growing patient, a good case for all 4 extractions because he is a bimaxillary bimax case. But patient was very reluctant for extraction. He said no extractions at all. So we had to go for other treatment modalities. The best option that we could choose for him was using 4 mini screws because he also denied for isolation. SHC and buccal shelf. So we had to go for mini screws. And we also adjuncted the procedure with interproximal reduction, especially in the posterior teeth. And we carried out the proximal reduction procedure, as you can see here in the premolar region. The tooth is recontoured so that the normal anatomy of the tooth is restored. Also, interproximal reduction was carried out in the lower arch as well, and some amount of reduction in the anterior teeth. And then a TAT spring was given for retraction from the mini screws that were placed between the first permanent molar and second premolars. The TAT screw or the NITEC closed coil spring was used here because the patient could not come for regular appointments, 3-week appointments. So this maintained a continuous force for a longer time. Hence the NITEC coil springs were used here, or the TAT springs. And this procedure was done after closure of the already existing spaces in the patient. As you can see here, he already had some spacing in his upper arch. All these were closed, and then the interproximal reduction was carried out. We started it from the posterior teeth first, and once retraction was done, where we thought that he needed even more retraction, that time we went ahead with the reduction of the anterior teeth. But anterior teeth reduction was very minimal because patient already had a elongated tooth. You can see here the length of the crown is greater compared to the mesiodistal width. So we did not reduce much in the anterior teeth, and we did maximum of interproximal reduction up to 0.5 mm on either side in the posterior teeth, because we did not want to give him a long tunnel shaped tooth. So keeping into mind the aesthetics, this was planned. And these are the post deboning photos. You can see here his lip fullness has reduced, his lip competence has improved greatly. You can see his tooth inclination. It is not very retroclined, but they have become upright. And we have also maintained the aesthetics of the patient. And I'll show you the comparison photographs. You can see how the incompetence has improved greatly with just interproximal reduction and retraction. And also these, I've put this occlusal photographs to show you how the anatomy of the tooth was maintained even after interproximal reduction. You can see there is no great difference between the anatomy of the premolars here. The contacts are tightly closed so that there is no room for plaque accumulation, and the anatomy is well maintained. So this is very important when you do an interproximal reduction. Do not leave any sharp edges of the enamel. Recontour it accordingly. Use polishing strips and then go ahead with the space closure. So there was one more case. She was a borderline class 3. And her chief complaint was that her upper teeth are irregularly placed. But when analysis was done, she had a class 3 relation, edge-to-edge anterior bite. And the skeletal relation also, it was a borderline class 3. So when we started with the treatment, we had informed the patient that surgery is an ideal option for her. But once the overjet is corrected, she can like decompensate it. We will analyze and reevaluate. And when we did the decompensation of the teeth, her lower teeth were uprighted, and there was only 2 mm of negative overjet. So we decided to go for a more conservative treatment approach, as the patient had was reluctant for surgery. And then what we did was, in the upper arch, we went ahead with a full size arch wire, that is 21-25, so that we gain maximum torque from the prescription. We did not do any interproximal reduction in the upper arch. We allowed for the arch expansion because we were doing a camouflage treatment in this patient. But in the lower arch, we used buccal mini screws and did IPR first, starting in the premolar regions. As you can see here, premolar and canine. We had done the interproximal reduction and then started retracting using the TAT springs. So this was the finish we got. After 2 years, her molar relation, the occlusion has settled very well, and a good class 1 molar relation and canine relation was achieved, and the overjet was also corrected. So you can see here the comparison, how her lips have improved from this shallow mentolabial sulcus. There is a good lip competence without any lip strain. And also intraorally, you can see a positive overjet was achieved. And when you see the lower arch, you cannot make out the difference between the reduced normal premolar before the treatment. So this is how the procedure should be carried out. The reduction should be done carefully so that the anatomy, normal anatomy of the tooth is not hampered. You can see here there is a surface contact between the canine and the premolars, which is less. You can see here some amount of plaque accumulation before the treatment, but after the treatment, that plaque accumulation is reduced actually. So moving on to the next case, she was a 13-year-old patient who reported to the department with forwardly placed upper front tooth, and she had a mild crowding in the maxillary arch, and patient had some amount of lip fullness, lip incompetence, and some very minor spaces in the maxillary anterior tooth. So first, she had a good class 1 posterior occlusion. So first we went ahead with the initial space closure, and then we suggested this treatment modality because patient was not ready for extractions. Even the third molar extractions, they were not ready. So we suggested them the next best option, that is use of 4 buccal mini screws and interproximal reduction in the posterior teeth as well as in the anterior teeth, and then retraction. So patient gave consent for this treatment modality, and hence the interproximal reduction was carried out. You can see here 0.5 mm on either side of the tooth were reduced. And first we did the reduction in the posterior teeth. Once the posterior teeth spaces were closed, then we assessed for the soft tissue parameters, and then went ahead with some amount of reduction in the anterior tooth as well, because she had a mild barrel shaped lateral incisors. So we eliminated that. And these are the final results where we achieved a good class 1 relation, and her lip incompetence was reduced. You can see here the comparison photographs before and after treatment. A very good lip seal was achieved. And also the pre-treatment and post-treatment photographs, they do not show major changes in the anatomy of the premolars or the anteriors. So this is how the procedure must be carried out. This is one patient who reported to our department with complaint of forwardly placed tooth. When asked for the history, he gave a history of getting his teeth disked. He said that the a disc was used to reduce the proximal surfaces of his tooth, and a removable appliance was given, which was done in a very crude setup. So you can see here why I'm showing this picture is because the interproximal reduction that is done in this case is very not up to the mark. They have just disked the tooth. They have not broken the proximal contact points. You can see the proximal contacts are still intact here. So there's no point in reducing the enamel in the incisal edges when you're not breaking the contact. You can see in the previous photos how the interdental gingiva is visible here after the reduction. So this will actually give us the space that is required after the proximal reduction. But when you do it halfway through without breaking the proximal contact, then it will not serve the purpose. So always make sure that the proximal contact point is broken and the surface is given a smooth finish, rounding off the sharp edges. You can see here how sharp the enamel edges are left. They were not even smoothened, even the incisal edges. So Later, this patient, we had to conduct some amount of interproximal reduction to break the contact, do some amount of enameloplasty to reduce the sharp edges. He also had some lacerations in his lips because of these sharp edges. But you can see here, the planning was not proper. They first straight away went for the anterior tooth reduction, where the long axis or the length of the tooth is already increased compared to the mesiodistal width, and they further increased it, resulting in reduced aesthetic outcome. So always try to carry out the interproximal reduction in the posterior region first, and when patient has a good class 1 molar posterior relation, try to do the reduction in all the proximal surfaces of the posterior teeth so that the class 1 relation is maintained. And if you want some amount of a class 2 correction, you should plan the interproximal reduction accordingly. When you want a class 2 correction, you will be wanting some amount of distalization of the maxillary posterior, whereas mesialization of the mandibular posterior. That time, use a single-sided strip, do more of the reduction in the distal surfaces of the tooth so that it results in a distalization of the maxillary teeth and more of reduction in the mesial direction in the lower teeth so that the class 2 correction is achieved. If you want a class 3, the reverse of it should be done. And proximal reduction is also a very helpful adjunctive procedure, especially during the finishing stages of your treatment. So when you're planning for an interproximal reduction, plan it meticulously, because if you do it at the beginning of the treatment itself, if you do on all the tooth surfaces, then later during the finishing stage, you will not be left with any more enamel to do the reduction and get the finish, especially for midline corrections or mild getting the good Andrews class 1 molar or class 1 or class 2 or class 3 molar relation. So plan your interproximal reduction carefully. Coming to the summary of this presentation, a meticulous treatment planning and case selection is very important for interproximal reduction. It seems like a very simple procedure, but treatment planning should be done properly beforehand, and it should be decided how much of an enamel should be reduced from which tooth surface, so that during the finishing stages also you will have some room for interproximal reduction where you can bring about the desired changes. And then relieving of the crowding and rotations is preferred before the interproximal reduction procedure. As you can see in all the cases I presented, we did not straight away go with the interproximal reduction. The initial alignment was done so that we have a good access to the interproximal surfaces, so that only the greatest thickness of the enamel is reduced without causing any atogenic sensitivity. And use of separators before the interproximal procedure, like the previous appointment only, you can just place the separator and place the wire and send them, so that in the next appointment there will be a mild space, physiologic space which has been opened up. You can easily carry out the interproximal reduction. And then wedges can be used below the contact point so that the interdental papilla is not damaged. Guide wires or soft brass wires can be placed, especially during the motor-driven interproximal reduction procedures. It is also preferable to place cotton rolls on the surrounding mucosa so that the surrounding tissues are not damaged. And polishing of the reduced enamel surface is very important. It is a very helpful adjunctive procedure to the interproximal reduction. As I showed the results of these studies, not just my study, but even the other literature support says that a polished enamel surface has less surface roughness compared to even normal tooth. So please you carry out the polishing procedure using any polishing strip after the interproximal reduction before the space closure. Then restoring the normal anatomy of the tooth, reduced tooth is very important. Do some amount of enameloplasty in the occlusal or the incisal surfaces, and also in the buccal and lingual enamel surfaces, so that the sharp cut enamel edges are not left out. This is very important because you will have to create a self-cleansing tooth surface to avoid any further plaque accumulation and leading to periodontal problems or caries. So the conclusion is, when an interproximal reduction procedure is carried out meticulously, following all these steps carefully, you will have a good oral health and also a very good treatment outcome. So it is not as simple as it seems. Please follow all these procedures, and hope you have benefited from this talk. These are my references. And I would like to end my session. Thank you for the Dentist Channel Online for giving me an opportunity to present in this platform. I thank my PG college, Kelly Dental College, my HOD, everybody, all the staff there, my guide, for supporting me and helping me going ahead in this field, because IPR procedure is very commonly used, but the recent studies were reduced because they thought many studies are already conducted before, but there is still scope in this field. And I also like to thank my college, Enamel Dental College, for supporting me. And thank you, Dr. Aparna, for all the support that you have given me. Thank you. I'm open for questions.
That was indeed a very, very informative and educative session. I especially enjoyed the part where you not only systematically talked about the theory of IPR, but actually demonstrated it through your SEM studies, and you showed few cases which made things very much clearer. And it's very true that, as private practitioners, many of us have this, conflict of interest that, probably by using IPR techniques, you might cause increased caries incidence in those patients. But through your webinar today, we actually learned that this, if properly done, this procedure can actually help in reducing caries incidence. That was really informative. So now, before taking up the questions, I would like to share our company presentation. DentistChannel.Online is the first digital dental media, and we offer our services for both dental professionals as well as dental organizations. As far as dentists are concerned, we constantly update them through dental news, articles, webinars, courses, events. There are several videos which are available for patients as well, clinic IT services, and we also provide Prime membership, and you can submit scientific articles, dental business, and several videos, like I said, and we also help you resell your old instruments. As far as dental organizations and dental business is concerned, we host events, we provide graphic designing, we provide social media support, website development, so all the participants are going to get participation certificate. So you can register for any of our events. We also provide consultation, content writing and designing, and you can list your business in our website or advertise with us. So we have conducted more than 700 live dental webinars and more than 25 dental workshops. More than 300 oral care videos are available under Save the Tooth hashtag. 40K plus participation certificates has already been issued, and there are more than 400 plus national and international speakers with us. So we recently have got a certification by the India Book of Records for maximum speaker participating in virtual dental program on oral implantology. You can avail our Prime membership. There are several benefits by availing our Prime membership. You can get a personalized account in DentistChannel.Online, through which you can access your profile. You can access all our webinars. So certain webinars are available only for the Prime members. So you can access those webinars. There'll be special discount on various dental courses, certification by recognized institutions with CPD and CTE programs. And you can always download your certificates from the website. There'll be regular updates and news about dentistry. You can access the scientific articles and recorded webinars. You can participate as a speaker or publish public awareness videos. So as I told, all the participants will be getting your participation certificates along with CPD, CDE, CE points. So why wait? you can now have this wonderful opportunity of being a Prime member just at $7.99 per year. And by using the promo code AP100, you will get assured discount. So these are our upcoming webinars for May and June. Thank you so much, Dr. Pooja. It was a pleasure to have you with us today. It was really educative and very informative session. Thank you so much. So we can take up any questions if there's any. Okay, so your session was too good. You have cleared all the points. So I was wondering, as far as interproximal reduction is concerned, what are the other things that we have to keep in our mind while doing this procedure?
Basically, when we are doing the procedure, the technique that we are going to use, it matters the most. Posterior teeth, if you are doing, as I said with the study, mechanical stripping is always better. But if you're doing mechanical stripping, use handles so that it is easy to access the posterior teeth. Anterior we can manage with hands, but posterior always use handles. And I would prefer aerator stripping in the posterior teeth because it is more easy, faster compared to the handheld reduction. Always try to use separators and break the contact so that it is easy for mechanical stripping. And derotation of the tooth is very important also to relieve the crowding. If you have not, if it is not possible to do that, then at least use a single-sided abrasive strip so that the adjacent tooth, which is in crowding or in rotation, the damage to the other enamel surfaces can be avoided and stripping can be carried out only in the required proximal surface. Then also use of wedges or guide wires like soft brass wire to avoid any soft tissue injury. Make sure that all the soft tissues are protected well. If possible, use small cheek retractors or separators to secure the tissue. And the one major thing that I would recommend is polishing of the enamel surfaces after any technique that you are using. I personally do not recommend chemical stripping because there is a possibility of soft tissue injury. The chemicals, if it is in gel form, it is okay. But applying it only on the reduced enamel surface is difficult. So I would always recommend mechanical or aerator stripping. Use proper burrs. Don't go ahead with your straight fissure burrs or any burr that is available in clinic. Use interproximal reduction burrs because it has a fixed diameter which is not more than 0.5 mm. So it ensures that the more amount of enamel is not reduced. So, and polishing, it's always the last procedure you have to do after reduction.
Thank you so much, Dr. Pooja. It was really wonderful. So we can conclude the session. Thank you so much.